Oh my goodness. I guess so.
You're live.
Yeah, absolutely. Okay. Recording has started. Yeah, right, we've got it. Can you see my screen? Has that worked? Yeah? Are there slides rather than just me?
Yes.
Yes,
Yes.
good. Because I can't tell. I can only see you guys. So brilliant. So yeah, so my name's Susannah. I'm a research fellow at London School of Hygiene and Tropical Medicine part of the time, and I also work as a GP in South London part time as well. And the team that I work with at London School has been particularly looking at infection prevention control, mainly in maternity units, in an attempt to try and reduce maternal and newborn infections. And so, sort of out of that team, going to change. Yeah, there we go. The sort of reason for focusing on that topic was because we realised that maternal infection was important. It still causes about 11% of maternal deaths, as well as having some long-term sort of consequences for some women and increasing the risk of perinatal death. But what we realised was that there actually aren't very many good estimates of how much maternal infection is actually occurring, so how frequent it is. Basically, what's there is from the global burden of disease models. So there's quite an early model for puerperal sepsis of 4% that's still quoted fairly often. And then more recent models, so from 2017, they're estimating what they call maternal infection. This is mainly postpartum infection, but it includes a whole range of infections, including urinary tract infections and mastitis. And so that estimate from 2017 was an incidence of about 12.5 million women, which works out at about 8%. And so estimates generally of maternal infection are challenged by the wide variety of different terms and definitions that are used, and so it's often very difficult to compare studies and compare these estimates. And so when we were trying to estimate, what might a baseline risk of infection be in a study if we were then going to do an intervention and reduce it, we found it very difficult to know that, and so I ended up trying to do this review to just have a look and see what's the evidence out there and how much infection might there be. So that's sort of where we started from, and there's obviously a lot of possible infections to choose, but the ones that we went for was this WHO term for a group of infections that they term maternal peripartum infection. I think this was in 2014. They produced guidelines for the prevention of these infections, and so their definition was that it was meant to be a bacterial infection of genital tract or surrounding tissues. So this was to include infection related to trauma at childbirth, so from Cesarean sections or perineal tears, occurring from onset of rupture membranes or labour until 42 days postpartum. And I think they were particularly interested in that because it's very directly related to the process of childbirth. It's a time when many women, most women now, are in contact with healthcare services. So there is a risk of us as healthcare workers actually increasing infection, but also key opportunities for preventing infection. And I thought it was an important group of infections to look at in this context, because if you look at studies of sepsis in the UK, then over half of severe sepsis cases are related to infections that would fall into this sort of term, this group. But as you'll all be aware, no one actually makes a diagnosis generally of maternal peripartum infection. It's not a term that's used. It's not a term that's used in research studies either. So to do the review, we had to sort of break that down into what are the constituent infections. And so what we were actually looking at was chorioamnionitis in labour, endometritis postpartum, wound infection from Cesarean section or perineal wounds, and sepsis. Now and then we wanted sort of standard definitions for those infections. So those came primarily from CDC and then from sort of international definitions of sepsis. The definitions of sepsis have changed over the years, but the studies sort of incorporated a time period when there were older definitions of sepsis. So in the review, we also included sort of systemic inflammatory response syndrome and then severe sepsis with organ dysfunction, which would be more similar to the definition of sepsis now. There were also studies that just reported on bloodstream infection, septicemia. So we included all of those within this group sepsis and then also looked at them separately. So for the review, we searched 8 databases. We sort of threw it quite wide. We used basically a maternal term infection term and then a frequency term. We obviously excluded studies where we couldn't get quantitative data on maternal peripartum infection, or where the infection was only there as part of a composite outcome like maternal morbidity, so couldn't be separated. We also excluded high-risk groups like only women who had Cesarean section, only women with diabetes, only women with HIV, where the risk of infection was likely to be higher than the general population, which is what we were trying to estimate. And then small studies and older studies. And extracted data on the study population, the design, what the definition of the outcome actually was that was used in that study, how long women were followed for postpartum, and the infection incidence. Might changing. Hang on. So then we appraised the quality of each of the studies, looking at how women were selected, could there be bias there, how much loss there was, and then particularly any bias in the measurement. And quite a focus was, was there a definition, and did it meet one of these standard definitions from that earlier table? Or certainly did it fall within one of those? Analysis was conducted in R, with meta-analysis to obtain the weighted pooled estimates for each infection separately, and then meta-regression to look at how world region and also how some study characteristics might affect the incidence of infection across the studies. So after removing duplicates, we had 31,500 studies. So this took a little while. We managed to exclude almost 30,000 through title and abstract screening and reviewed the full text of 1,500. 2 we couldn't find the full text, but all the others were looked at, regardless of language. And we included 111, of which 99 made it into the meta-analysis, or one of the meta-analyses of these different outcomes. So of those 111, they covered 46 countries, but America and Europe were very overrepresented in that. Nearly half of the studies were just conducted at a single hospital, but there were also quite a number of studies that tried to represent an entire country, so either using something like birth certificate data or hospital databases from the whole country, or particularly in the US, they have a number of nationally representative hospital databases like the National Inpatient Survey, which takes a sort of 20% representative sample of all admissions. 4 randomized control trials, 2 before-after studies, and then all the rest were cohort or cross-sectional studies. And overall, the quality was fairly poor. So only a fifth met all 5 quality criteria and were considered high quality. And particularly, the definitions were bad. So there was often no definition. There was just, it'd say endometritis, but no other definition attached to that. Or they didn't fit within one of the standard definitions we were using. Only 40% met that criteria. So these are the main results, both for all the studies and then for these high quality studies meeting all criteria. So you can see quite clearly that there are far fewer of the studies that are high quality, particularly wound infection, where the definition was rarely given. So there's only one study there, which you can't really interpret in terms of a summary estimate, because it's just one study from Brazil. I think what's quite striking is that chorioamnionitis came out as the most frequent infection, at about 4%, whereas other infections were 2% or lower. Sepsis, unsurprisingly, was much lower at sort of 0.05% among high quality studies, and that's as expected. Yeah, and some fairly wide confidence intervals, and we also looked at what are called prediction intervals, which are sort of saying if you had did another study in the future where
domestic violence has gone up, and calls to the police for that reason.
Okay, that gone? That's not me. Yeah, prediction intervals, which are saying if you did another study, what might the estimate be? And those are much wider than the confidence intervals. So just to look at a couple of the outcomes in a bit more detail, just to understand what these summary estimates really mean, because you can sort of say, oh, here's a summary of 4%, but what does that really mean? So this is wound infection, and I'm sorry it's very small, but just to give an idea. And this is broken down by region. So we're starting with America and Europe at the top, and then other regions below. You can see more studies from America and Europe, and actually wound infection was the one outcome where other regions were much better represented. So for the other outcomes, it was a lot sparser than this. But within each of the regions, you can see there's quite a range of infection incidents from these studies. So it does vary quite a lot. So there's a lot of heterogeneity. If you look at the pooled incidence by region, here you've got just under 1% for America and Europe, compared to 6% in East and Southeast and Eastern Asia, or sort of 3.5% in Sub-Saharan Africa. And there was statistical evidence of a difference in infection incidence between world regions for wound infection. There wasn't evidence, but there was a trend towards that for some of the other infections as well. The sort of study characteristic that came across strongest in all the meta-aggression was looking at what we referred to as the extent of the study population. So studies of single sites, single hospitals, had a higher infection incidence on average compared to those with more than one hospital. So either multiple hospitals or representing a state, or these sort of national databases. And that could be because single site studies will often be a tertiary hospital with higher risk women in, or in lower middle income countries where more women are delivering at home. Again, you are going to have your higher risk women in hospital. So you could expect those single site studies to be sort of over-representing infection compared to the population generally. However, on the other hand, if you have national databases which are collecting a huge amount of data on all admissions, you are likely, when you look at one specific event like peripartum infection, you are likely to have missing data, to have misclassified data, which means you actually might underrepresent from those. Also, a lot of those databases only had information for the woman while she was in hospital for her delivery. So infections occurring after discharge usually weren't captured by those databases. So again, you're going to have quite a large underrepresentation of infection, underestimate of infection. So we kept both in the summary, because probably the true risk is somewhere in between the two. And then just one other outcome to look at. So this was sepsis, and rather than world region, this is showing the breakdown by severity. So you've got here your systemic inflammatory response syndrome, again with a variety of outcomes. Then severe sepsis with organ dysfunction, and bloodstream infection, which is a much more consistent, actually one of the most consistent groups. So you can see here with the severe sepsis with organ dysfunction, it sort of seems very low. But then you've got this one sort of outlier almost, which is a study from Bangladesh from a single hospital. And so one might think, well, is it that infection's higher in Bangladesh? Is it that they're not using such good sort of definition or diagnostic criteria? This was said to be genital tract infection with shock. So it should have been, I think, fairly clear that it was severe infection. The other thing that was different, this study followed women until 32 days postpartum. And certainly with sepsis, the length of follow-up influenced the amount of infection that was reported in the studies. So if studies followed women for more than 7 days, more than the first week, then they found higher rates of infection. And that was very clear there. So actually, although infection was, SARS was a bit higher than severe sepsis, again, there wasn't statistical evidence for that difference. So just in summary, Um, there was a reasonable amount of infection globally still complicating childbirth, and infection during labour seemed to be particularly high. The incidences that we came up with were lower than those global burden of disease estimates I presented at the beginning of sort of 4% or 8%. But of course, what we were measuring was different to what they were measuring. We didn't include urinary tract infection, which they did. We certainly didn't include mastitis, which they did. So it's very difficult to sort of compare these outcomes. There was a lot of variety of heterogeneity in the outcomes and then in the study designs, and especially the infection definitions. And so certainly for future research, this is something that really needs to be considered, using standard definitions, and then especially following women up after discharge from hospital, because not the majority of studies just hadn't done that. There's also obviously a lack of data for low middle income countries, especially at population level, and that really needs strengthening. But despite all those limitations, I think the study does provide some idea of a sort of baseline estimates which can be used certainly for future research, but also just highlights the ongoing importance of infection prevention to reduce these infections. Something which I think probably in the current COVID climate we're all far more conscious of at the moment, and also the need for proper sort of antibiotic prophylaxis and practice, which I think in the UK is hopefully pretty good, but both Laura and I have experience in parts of Africa where it's just not routine to give pre-op antibiotics for emergency caesarean section, as it should be, where there's often delays in getting women from community into hospital and then from hospital into theatre, which again increases the risk. So there's definitely more that can be done to prevent the infections. Thank you. Yeah, I think.
Thank you very much, Dr. Wood.
You're welcome. So I unshare my screen. You don't need to see that. Yeah, here we go.
Okay. So we will open the floor up for discussion now. Does anyone have any questions, comments? You can unmute your audio at the top of your screen.
I'll go first.
Thanks.
Just to see that I understood correctly, when you say you excluded high-risk groups, you mean you excluded studies that studied exclusively high-risk groups, right?
Yeah, absolutely. So we're obviously what we were aiming for was studies that had, that captured a sort of population,
yes.
Right, or something close to the average population. What we did include, which could have brought the estimates down, was studies that only included what might be considered a low-risk group. So if they were only looking at vaginal deliveries, we still included them.
Okay.
Because that was, in that sort of situation, that's still going to be the majority of deliveries. So we included those, but we didn't include ones that were only caesarean section. But the ideal was obviously both. Yeah. I did look. There was a review of infection and other complications related to caesarean deliveries in Sub-Saharan Africa that came out just before this, I think. And so they had a rate of infection of about 12%, 13%, as I remember. But that was just from caesarean section. And then if you looked at their sort of average rate of caesarean and then sort of factored that in, it would work out at about 1.9% infection overall.
Okay.
Yeah, which then doesn't account for any sort of perineal wound infections, but that was very similar to our wound infection and actually a bit lower than the infection, the pooled infection for Sub-Saharan Africa. So it was good to sort of do that comparison.
We've got a question from Yusuf Baho on the chat. And they've said, hi, thanks for the review. Practically speaking, how did you find and remove duplicate studies at the beginning?
Nice question. So I used a sort of review database system called Epi Reviewer, which is hosted by Institute of Education. And they, within that, and it's, I mean, actually they have in things like EndNote as well, and I imagine Mandalay, they have systems for identifying duplicates. So they sort of flagged up duplicates and would remove them. It didn't identify all of them, because sometimes you'll get duplicates, but there will be differences in the way something's written between one and another, especially if you've identified them from different databases. So there was a certain amount of manual, just literally going through the studies and seeing where things matched. So that was a little laborious, but the majority were actually picked up by the software, fortunately.
I've got a question here.
Mm.
Can you hear me?
Yeah.
Yeah. Just looking at the paper, one thing I was trying to work out, if you looked at mortality because of postpartum infection. So I didn't see that in your paper. Was there a reason, or I might have missed it? So is there a reason why you decided not to include that? One. And the second is, as it's especially the GASOC group is interested in surgery, the wound infection is in your regression table. It's saying that where is it? Yeah. So the day 7 follow up for the meta regression in the wound group. You've got 2 studies in there, which with the odd ratio of 3.57, with a quite a wide confidence interval. So just from an LMIC point of view, what are the implications of your study when it comes to the wound infection? Because I know not many studies would have followed their patients up.
No, absolutely. So wound infection here included both Cesarean and perineal wound infection. So it's because different studies looked at different things. Whatever they included got put together in that. So it's not just Cesarean wound infection. Although a lot of it will be, because there were some studies within that didn't actually include any Cesarean sections. They just had vaginal deliveries and then wound infections related to that. Although even then they were surprisingly high from some of the, I remember, I can't think where it was, but it was in one limit and an IC country, and it was still high. Like I was saying, so there are more reviews that have been done of just Cesarean section infection. So certainly there's one recently from Sub-Saharan Africa, which is just focused on that area. In terms of follow-up, I mean, like you say, the confidence intervals are it looks higher in the first 7 days. If they only follow to 7 days, which is not what you would expect, the confidence intervals are wide. There are only 2 studies there. I mean, what you're actually comparing to is the 17 studies that only followed until discharge. So that's your baseline, and then what you're saying is the odds of infection, according to this, are sort of 3.5 times higher if you follow to 7 days, and then we're saying only a little bit higher if you follow for longer. It's very difficult because there's not that many studies going in, because there's so many other differences in the studies. It was often quite hard to show effects of those sort of study characteristics. So it's not great data for some reasons. That's the problem. But I mean, certainly other studies following wound infection as well, I think generally show a peak at around 7 days, but then wound infection continuing certainly till 14 days, if not later. So I mean, we know that from other studies that have been done. So I'm sure your experience is probably similar.
Well, I'm not an obstetrician or gynecologist. I think we've got Soha on call who has done the Lancet study on C-section. I don't know what your thoughts were, Soha. Can you hear us?
The answer.
Otherwise, we'll move on to the next question.
Okay, that's fine. They might chat back or something.
Could I ask a question actually? Does anyone else have questions to ask?
I think there are a few questions on the chat.
There are 4. Sorry, I've been negligent. Let's read them out first. From Aqua Asif.
Very kind.
Yes.
That's very kind.
I also agree. I've waded through some meta-analyses that I wasn't able to follow at all, and especially with such a big topic that you've picked, I thought your layouts, with especially the world region distribution, is really, really helpful.
That's really good.
Inez. Actually, Inez, do you want to read? I don't want to be reading out other people's questions. Feel free to unmute yourself and ask.
Yeah.
Hi.
Hi there.
Very interesting, by the way. Thank you for the paper. I just wanted to ask you, which I found interesting, how would a further study that you might or another team might do on this topic include women infection rates in women who actually stay at home instead of hospital after childbirth? Because you mentioned the fact that many of the results could be inconclusive because a lot of women stay at home and they are not followed in hospital. So do you think there's any chance that you could include more of the general population?
No, it's a really good question. So the studies we included, we were looking for everything, and so there were some studies that were just conducted in the community, and they were women who might have delivered in hospital, but in some cases many delivered at home and were followed at home. So they had, sort of often community lay workers, sometimes nurses or midwives who were visiting women at home at a certain point after their delivery to assess. There was often issues with the sort of quality of measuring infection in those cases. So sometimes they were visiting women 3 months later, but only asking about the first month, or even visiting 6 months or more later, but asking, for women's report of symptoms in that first month. So it was, I think, not as, interpreting the results was going to be quite difficult. I've been sort of recently involved in a study in Tanzania where we've been looking at whether we can use telephone surveillance now that many more people have mobile phones.
Yeah.
It's been, again, hospital deliveries because it's an easy way to identify women, but it could be done at home if you had lay workers there collecting them, but then having nurses phone 7 days, 28 days later and asking about symptoms of infection and complications and things like that. So that might be a possibility for future that would probably be able to reach more women more quickly. Because it's quite intensive otherwise, having to get lay workers or nurses out to visit and examine and that sort of thing. But certainly any community studies were included as well if they met the inclusion criteria. So there were a few, but not many.
Thank you.
And I realised I didn't answer your other question, Noel, about mortality, about death. Which is a very reasonable question, and one that did come up during the course of it. It wasn't something that we set out to do because there have obviously been other earlier reviews of mortality more generally. And to be honest, a lot of studies didn't report it. And also maternal mortality overall is low. I mean, it's much higher in low middle income countries than in the UK, but it's not a frequent occurrence. So unless you've got very big studies, it's quite difficult to pick up. So we didn't. It is something that potentially I could go back and find the studies that have it and pick it out. It is something that's sort of at the back of my mind, but there hasn't been the time to sort of go back and do that. But yeah, it would also give a bit more sort of credibility. It would help if you compared mortality rates in some of those studies and what we know about mortality more widely, it might sort of help confirm incidence as well.
Yeah, especially probably in the sepsis group, you might find.
I think the sepsis
Right.
studies, there will be more reports of mortality within those studies than the other
Yeah.
infections, for sure.
Oh, fantastic. Thank you.
Welcome.
Another question from Aqua. Do you want to?
Yeah, sorry. Hi. Again, I was the cheesy person to compliment you. Sorry. But yeah, I didn't read the study on, I think it was Osmondson 2011 from your figure 2.
Yeah.
And the incidence rate is really, really high in comparison to all of the others.
Yeah.
Am I right to assume that it's because of what you said previously, that it's to do with singleton deliveries or the fact that they were just single facilities?
Yes. Now I would have to find my.
Yeah, no, I understand. I'm sorry.
No, it's fine because I just with 99 studies I don't
I completely get it.
remember them all. But this was. Hey, wait a moment. Was this the Remind me the infection outcome, because was this the chorioamnionitis, wasn't it?
I can pronounce that.
Yeah, it's fine. Chorioamnionitis. Where are we? This was a very small study. It was actually in the US, which is interesting.
Yeah.
There were only 102 women in this study, so that already you sort of get a bit concerned about it. And it was just at one hospital. It was actually meant to be low-risk women at term. And yeah, they found this ridiculously high rate, and I don't know why. I think it was a study that was sort of more specifically, it was medical record data, but they were very much looking for chorioamnionitis. So whether it was in a much higher risk group, or they just had a much sort of broader term for identifying them. It's not always easy to tell exactly what's going on, but it was a very small, 100 women in this sort of situation is a very small study, and I think that is probably one of the biggest issues with it.
Yeah, no, thank you so much. It was just worth asking because it
does stand out. There were a few other studies that sort of stood out like that, and we actually looked again statistically at whether they were outliers and removed them from those graphs because it was really upsetting. It the way the weighting works, though, it doesn't make a huge difference to the overall estimate, which is good.
Okay, thank you.
Welcome.
So I just wanted to ask a question because I found part of the presentation particularly interesting. The part where you said actually nearly half of the studies were from one hospital. So I just wanted to get a bit more understanding because I'm been going through the study actually here on my phone. I can't seem to find the specific details of which hospital it was.
No, sorry, not as in from the same hospital, but they were. Studies in a single hospital each.
Mm-hmm.
So it wasn't that there was just one hospital that they kept studying. Sorry, I wasn't clear. No. No, so it was just that though about almost half of studies occurred in just one hospital rather than studying women across a number of hospitals or across a region or across a sort of larger population.
So was there any particular... Was there any particular reason why they had so many studies in that hospital? Were they like a national centre for maternal sepsis or anything like that?
So what I'm saying is it wasn't one hospital. There wasn't one hospital. It was that the studies, rather than the studies including many hospitals.
Yeah.
Each study included a single facility, but it was a different facility.
Oh, I see. So it wasn't one actual hospital.
It wasn't just one
Each
hospital
study was on
that
a
had
hospital.
a ridiculous amount of research. No.
Oh, okay. All right. Thanks for the clarification.
It would be a bit concerning otherwise.
Okay. All right,
generally, if there were some groups of hospitals that were studied sort of more than once, and if those studies overlapped, then I would remove one of the sets of data because it was clearly measuring the same thing.
Okay. All right. Thank you for that.
Look, there's a very interesting question here. Noleg. Shall I read the question, or does Noleg want to ask? Yeah, are you sure? So it's saying, do you think paper could be a foundation for a standardized peripartum infection classification system? Oh, I'm not sure that this paper by itself could, but I think there probably is a need for more standardization. And I know a lot more work has been done on neonatal infections and standardization and sort of classifications, and a call for sort of meeting good research guidelines criteria. So there's sort of specific strobe guidelines for now for new research studies of newborn infection and things like that. So yeah, it would be a nice thing to see develop, but I think it needs a bit more than just this paper. With the newborn stuff, I mean, they looked at what was coming out of studies and then came up with some criteria, and then did a sort of Delphi exercise, so putting a group of experts together internationally, sending out suggestions and getting feedback, and almost voting on things from that. So it might be that it needs a bit more work like that. As I said, the definition of sepsis has been updated for the adult population generally, and more recently sort of early 2017, WHO did an exercise and proposed a new definition for maternal sepsis as well. So it may be working with that group would be a way to look at it. I don't know, because WHO has done this GLOSS study quite recently, which is not yet published, but I think is getting that way. And one of the things they wanted to look at, that's again broader because that's infection throughout pregnancy as well as postpartum. And they, again, I think are interested in criteria for infection and for sepsis, sort of diagnostic criteria. And I'm not sure what's coming out of that. So it might be when that's published would be a good time to then sort of look at these definitions again. Laura might know more about that. Yeah.
Yeah. So I was involved in the GLOSS study in South Africa. So I've seen the manuscript, which I think has been accepted now in the Lancet Infectious Disease, Lancet Global Health, but hasn't been published. I have to say I found it a little bit not fulfilling all expectations, because they stated they were setting out to really identify criteria that would identify women with maternal sepsis, which is a category with a high mortality. Those criteria exist for the normal adult population, but because of physiologic changes in pregnancy, they can't be readily applied to pregnant women. But I don't think, I mean, if you look at their study protocol, which they published in advance and what they said they would do, and then now what they've published, I do not think they answer all their own questions. So I still think it's very much an ongoing work. But it does give some info on, it makes like a snapshot. There was this inclusion week where they try to identify all pregnant women with some kind of infection, and then follow up. So it does give an idea of incidence of infection during pregnancy.
Or prevalence, I think, isn't it?
Yes, absolutely.
Yeah.
If I could just ask a very quick final question, just because we're talking about definitions and things. Again, I'm not an obstetrician, so might be way off on this, but how would you feel about, because I've just been looking at the chorioamnionitis figure and the paucity of studies from lower and middle income countries, but also preterm birth and preterm labour. You know, I think, if I'm not mistaken, it's chorioamnionitis is probably one of the biggest. Yeah. So in terms of getting more data for that particular infection, you know, which has so many policy implications in terms of, you know, antibiotic cover for group B strep and things like that, would it be sensible to include preterm labour just from low and middle income countries as a part of maternal peripartum infection definition, or do you think that's going too far? Sorry, that's a bit of a...
No. It's an I mean, I would find it difficult to include preterm labour by itself as a definition of infection. I think that doesn't work.
It's not specific enough, yeah.
And certainly, I mean, there's sort of two ways to go, because infection in pregnancy is one of the causes of preterm labour. So the infection can come first, and then I don't know about preterm labour. Certainly, sort of, pre-labour rupture membranes is then a risk for infection developing. So there's different pathologies going on, and I think it would complicate it just to say, because there are other causes of preterm labour as well, and I think just to say that's all infection is not correct.
No, it's too general to be a sort of surrogate marker of chorioamnionitis, something like that.
No, I mean it probably relates, but I don't think you could classify all of it as chorioamnionitis at all.
Thank you very much. Do we have any further questions for Dr. Wood before we move on to Dr. Cornelissen's presentation? Thank you very much. And now we move on to our second presentation of the evening.
Okay, let me see whether I can share my screen. Yay! So far, so good. Okay, cool. I'll present myself first. I'm Laura. I'm Belgian, but I did study at the London School of Hygiene and Tropical Medicine for 1 year, where I met Susannah, who supervised my master thesis work, whatever. I graduated as an obstetrician in June last year, and I am now currently working in infectious diseases for the general population. So these are busy times because I'm in the epidemiology of infectious diseases department of our Scientific Institute of Public Health in Belgium, in the midst of a little bit of a COVID crisis. I did also work 1 year in South Africa as an obstetrician, which was an experience and has definitely strengthened my belief that infection prevention and control are tremendously important parts of good care for women. So South Africa was after I'd done this analysis, but I think, I kind of still support the conclusions we drew from the study after having seen how it works in practice. So. This nice little graph is not much news. So we know there's still a lot of maternal deaths. They're very asymmetrical in low and middle income countries. Most are caused by haemorrhage, hypertension, and sepsis. And the beauty of these graphs is that they're so clean and well defined and nicely clear cut. But I'm sure all of you, as you are clinicians, realize that this is not how it is in practice. And so a large concern might be that by only using the main cause of death, that we're missing a lot of the contribution that sepsis might actually do. So the woman trial, I'm not sure whether you guys are familiar with it, but it was a trial also coordinated at LSH-TM, which included 20,000 women in 21 countries that looked at the effect of tranexamic acid for postpartum hemorrhage. So that was the primary outcome of the study. That was what it was designed to do. But of course, this was a really, really big data collection they did, and a valuable resource. And whilst they were analyzing the results, Ian Roberts, the principal investigator, also saw that they had quite a lot of cases of sepsis. And so he asked Susannah, who then asked me whether we could have a closer look at this. So, as I said, it's a secondary data analysis of a large RCT, which was designed to look at postpartum hemorrhage and the effect of tranexamic acid. The outcome, again, was sepsis, the way they had defined it in the trial, which is not what we should currently use as a definition for maternal sepsis. So as Susannah already mentioned, WHO has revised the definition of maternal sepsis to be more in line with the revised sepsis 3 definition for the adult population. So infection plus systemic inflammatory response syndrome is no longer should no longer be called sepsis. You should only speak of sepsis when there's severe organ dysfunction. But at the time that the inclusion of the study was done, this was still the definition of sepsis. So we in the paper also call that sepsis. However, to be able to compare with other populations or to go more towards the terminology that's currently used where sepsis is only defined when there's organ dysfunction, we created a new variable which we called severe sepsis. So as main exposures, because we hypothesized that maybe not only the fact that these women had a hemorrhage, but also that various invasive treatments were done to stop the bleeding, that these interventions in themselves could actually increase the risk of sepsis. So that's what we looked at as main exposures. We had manual removal of placenta, hysterectomy, raised sutures, artery ligation, intrauterine tamponade, or laparotomy for other reasons. So we did logistic regression in STATA because we wanted to look at the effect of our main exposures, but obviously there are several confounders, so we wanted to be able to adjust for those. So age, type of delivery, because obviously Cesarean section does not, well, obviously a Cesarean section does not have the same risk of infection as a vaginal delivery. It's higher risk. Whether or not it was a hospital delivery, what the primary cause of hemorrhage was, and then bleeding severity. Because, well, I think you can imagine if a woman is already severely shocked, then all her natural defenses against sepsis or against infection are much lower. So this is a factor to take into account. There were a lot of facilities, 193 hospitals, but I do think you can imagine as well, it was a study that was conducted in a lot of countries, in a lot of facilities. I think it's fair to assume that there might have been some clustering by facilities, that some facilities had different infection prevention standards than others. So to account for this in the model, we used random effects. So a bit on the data set. So there was data on sepsis available for 20,018 women. It was very complete. There was missing data for only a very, very small part of them. 483 deaths, unfortunately, which gives an all-cause mortality of 2.4%. This is, of course, a study population that all have postpartum hemorrhage, so that there is a high mortality is not that surprising. And we had 365 cases of sepsis, so 1.8%. And if we looked at only the cases with sepsis, but also organ dysfunction, then we had 104 cases of severe sepsis, so which was still 0.5% of the total population that was included. To give a bit more of an idea of what the study population was, Most of women delivered in hospital, so it did include some women that delivered outside hospital but were then brought in with because of the hemorrhage, but almost 90% actually delivered in hospital. 96% did receive prophylactic uterotonics. There was a high cesarean section rate of 29%. And to have an idea of the exposures, 1,400 received the intrauterine tamponade, and almost 1,000, or just over 1,000 hysterectomies were done. So key results. So we analyzed for both sepsis and severe sepsis, but as I said, the group of severe sepsis was smaller. So you'll see that in for all of the odds ratios, the confidence intervals are wider because there's fewer events. So we did see that after correcting for other confounding factors, that it seemed that interventions like hysterectomy and intrauterine tamponade independently increased the risk for sepsis. And the most important one, the biggest effect seemed to be for the so-called laparotomy for other reasons. So what does this mean? In any case, in this population, there was a high sepsis risk, 1.8% of all women. That's high compared to the numbers Susannah just presented. In this population, we only had women with PPH, so in the study itself, we couldn't compare with a control group of say, unhemorrhaged women in the same hospitals or whatever. So we could only look at previously published literature for the general population, but then we hit this point that it's very difficult to compare with previously previously published literature because of all the differences in definitions and what is sepsis, what is maternal sepsis, puerperal sepsis. There's so many terms that are used. So why do we have this high rate? Because even if we, I think even if we put all the differences in definitions aside, compared to what is generally to be thought, this was a high incidence. So there are definitely a few factors to take into account. These are women with hemorrhage, so if they're severely hemorrhaging, then they'll be hypoperfused, which does increase your risk for bacterial translocation. They're anemic, which is not very good for your defense against infections. As I said, there was a high rate of cesareans, much higher rate than you would expect in the general population, and cesarean sections are a known risk factor for infections. But as turned out from our logistic regression analysis, the interventions themselves that were done to stop the bleeding also increased the likelihood of infection. And we got some feedback from reviewers on the article that yeah, that might be true, but actually what's the importance? Because surely you'll still do the tamponade if she's bleeding out. And of course, I've done intrauterine tamponades. I'm not saying it should not be used. But I do think it's, especially in these circumstances where it's extremely stressful, it's easy to forget infection prevention, and it's a pity because there's really no sense in saving a woman from bleeding out if after that she dies because of an infection. And I think it's therefore a bit weird that neither, I mean, I haven't checked lately, but when I was doing this, which is like 2 years ago, neither the American College or the Royal College of ONG guidelines on treatment of PPH talked about antibiotic prophylaxis at all. The WHO guidelines do mention it for intrauterine, for manual placental removal. For things like hysterectomy, I think it's undebated in the elective setting that you give antibiotic prophylaxis because you open the vaginal fold, which is a contaminated space. But as I said, again, these are stressful circumstances, so I think it's good to include it also in guidelines on PPH, because if you do drills, it's a thing to bear in mind. I do not have the response to how can we avoid this. We did not have any information on prophylactic antibiotics in our studied population, because, as I said, the woman trial was not conceived to look at sepsis. It was looking at postpartum hemorrhage. So we do not know, but I think so. More research needs to be done, especially on antibiotic prophylaxis for intrauterine tamponade. There is no consensus at all. There are various regimens given. Some give triple antibiotics IV for 7 days. Others give a single shot of cefazolin. So it's definitely a topic to still be researched, regardless of whether you're giving prophylaxis or not, I think it's the risk of infection is something to be bear in mind when treating a woman with PPH and in the days afterwards, because here we come again to what we were saying before, that the hemorrhage is instant and you'll pick it up and you treat it and you'll discharge the woman. And she goes home, and who knows what happens, because the sepsis is not the immediate; it has a later onset, and therefore might go undetected or be underrepresented in statistics. But it does has serious consequences. I think that was a quick run through. So if you have any questions, I'm definitely up for answering.
Shall I go for, anyone? Just ask the first question. Was the study powered to look at sepsis?
So it was not meant to. It was not an outcome when the study was designed. But as you see, we did find a relation.
But to be honest, I mean, like I said, just before the lockdown, when I went and did my big shop.
So we did find associations. So there's no power issue. If we didn't find an association, then you might wonder, did we not find it because it was underpowered, or? Yes. But we did see associations. Whether you believe
absolutely,
those are...
I believe the results. I just wondered about the other invasive ones as well. That I know you saw sort of the significance of results for hysterectomy and then the tamponade and laparotomy. But I wondered.
I have to say I did not do power calculations or sample size or whatever. It's true. What was I thinking? Oh yeah, no, it's because one of another comment we got from a reviewer was that he was saying, yeah, but I mean, this was not the primary objective of the study, and you've just tested so many things, so now you came up with a couple of significant values. So I mean, this doesn't mean anything. Your odds ratios are small. I think I disagree. I think it's definitely true, and so there's a lot of limitations to be thought of. It was not a primary outcome. There might be confounding factors, for instance, for laparotomy, but also for hysterectomy. It might be that it was actually the other way around, and the hysterectomy was done to treat an infected uterus and not because of the hemorrhage. But I do not think it will be I don't think it will be the majority. For hysterectomy, we did have a bit more information in the data set, and so for 11%, the reason for hysterectomy was to remove a severely damaged, ruptured, or something else, I don't remember it, uterus. So there will be some of them where it was the other way around, even though they got clear instructions on how to fill out the outcome form, etc., etc. But as I said, it's not as if we just threw in all the variables we could find and then looked for significant associations. I do think there's a lot of biological plausibility associations if you've seen how they do the intrauterine tamponade. I'm gonna stop sharing my screen because otherwise I don't like.
Aqua's just commented saying, thank you for highlighting the absence of clear guidelines for prophylactic antibiotics. For two of the major obstetric and gynecological colleges, that a lot of other countries are also looked to for guideline formation, actually.
Yeah.
Any other questions? I've got a couple more in reserve. I'm holding back so that I'm not a question hog.
Can I ask a question? Sorry, I've got a blank screen. Can you hear me okay?
Yes, we can.
Well, I'm Kathy Howell. I'm an obstetric registrar in Bradford in England. And thank you so much. I think it's really interesting, and it's great that you're taking the opportunity to look at that information from the main big study. That's really interesting information. I just wondered whether there was any outcomes with regards to venous thromboembolism, because looking at your information that you've gathered, you've looked at sepsis and haemorrhage, and I think venous thromboembolism is quite often very understudied and underpowered in low and middle income countries. Did anything at all come up about thrombosis at all?
They did look at it in the woman trial, in the original trial, because they were giving tranexamic acid. So they're, causing adverse events by increasing the number of venous thromboembolism was a concern. They did not see an increase after giving tranexamic acid. I gave loads when I was in South Africa, because when I was doing Cesarean. So, but I don't remember by heart what the incidence or the prevalence of that was in the original woman trial. But there is info on it in any case, because that was specifically one of the outcomes they collected because of the worry for tranexamic acid.
Yeah, absolutely. And I wondered, just because of those two big risk factors as well, the haemorrhage and the infection, whether there'd been any look at whether there was an increase in thrombosis afterwards. But yeah, thank you.
True. No, I didn't look at it. I think it's a very relevant question in these days as well, because with the COVID, they're also talking all about infection and thromboembolism, and then obstetricians are also going wild about whether or not they should anticoagulate. But I don't know in this cohort.
I think the Royal College guidelines are set to change, because certainly in the past 3 hospitals I've worked at, antibiotic prophylaxis for major obstetric hemorrhage has been part of the local trust policy. So I reckon it will definitely change in the Royal College shortly.
Yeah, I do think in most, the hospitals I worked in Belgium, we also gave it. So I do think it's, as I said, for intrauterine tamponade, if you look at the studies that have been done that looked at the efficacy of the intervention, then almost all of them actually did give prophylaxis, but it's just not very well described what you should give and whether it's it's definitely not evidence-based, I think, which is true for a lot of the things we do, but
I think quite often in low middle income countries as well, I've worked in Uganda, where people as a standard are given cefuroxime metronidazole with normal vaginal delivery or operative delivery, so it must be difficult to decipher when I bet a lot of the countries that were involved in the woman study were actually giving antibiotics out as a standard.
Did they give them like standard?
Yes, oral cefuroxime and metronidazole.
For vaginal delivery, okay. Yeah, no, true. I mean, in South Africa, that's the other thing I was thinking as well when we were talking earlier about postpartum infections and what is considered an infection. I know when I was working in South Africa, the interns in the maternity ward, as soon as any woman had a tachycardia, they would give her IV antibiotics, and it drove me crazy. Because I mean, there's a lot of reasons, and surely infection is one of them, and we had high infection rates, but but they couldn't be bothered to do any other diagnostics, so they just wrote up IV antibiotics.
Thanks a lot.
I've got a question for Laura. Looking at your table 2 with the multivariate analysis on the risk factors for sepsis, obviously laparotomy stands out. It's quite obvious that that seems to be one of the main variables, which is the risk factors for sepsis, and also for your severe sepsis table as well. It is pretty high compared to the rest. And then looking at the data from the original study, they describe that there's a significant reduction in laparotomy to control bleeding with tranexamic acid compared to the placebo group. So, I mean, this is just like a comment, really. Do you think that it does sound very obvious, but should the LMICs focus more on bleeding control to start with, to avoid long-term effects of getting into complications like risk factors like laparotomy, then leading into sepsis, which seems to be like a chain reaction almost?
Yes, of course. Of course, I mean, active management of the third stage of labor, giving prophylactic uterotonics, avoiding prolonged labor, and early recognition and aggressive treatment of postpartum hemorrhage are, of course, very very important to avoid that you need to do more invasive steps, because any invasive steps will increase or has consequences and potential problems. So yeah, surely if you can avoid invasive treatments and operative treatments, because it's not only the infection, it's the going in, it's the anesthesia. There's a lot of things that can go wrong. So clearly, I told you I used loads of tranexamic acid when I was in South Africa.
But from your experience, or whoever has worked in obs and gynae in the LMIC, is tranexamic acid widely used?
I do think so. Well, I worked only in South Africa, so and this was a tertiary hospital. It was in a township, but it was a university hospital. There, at least, the results of the woman trial were very well known, and it is a cheap, intervention. I still met with some, whenever I asked for it, there were some anesthetists that were a bit like, oh, but she's already obese. We're gonna get a DVT here, doc. Are you sure you want to do this? So yeah, I can imagine people still being a bit reluctant because they're afraid of thromboembolic complications. But I think they did. I think they have widely made known the results of the woman trial. It was a big trial, but it was big news as well.
Yeah. Great. Thanks.
I don't know whether anyone else. I have difficulty judging the audience here. I don't know whether anyone else wants to comment on that.
Kathy, Soha as well, yeah.
I've worked in Malawi, but it was pre the woman trial, and then no one used it. Just speaking to colleagues there now, I don't think it's used as often still, but I think it may be availability rather than lack of evidence. So I don't think it's still widespread. And when I was in Uganda, I don't think they used it much there either. That was post-woman.
Okay.
Yeah.
Yeah,
I
when
just
I
don't know
was
very
in
much about.
Uganda,
Oh, sorry.
sorry,
Go.
when I was in Uganda, the woman trial was going on, so they were using tranexamic acid at that time because it's just misoprostol there, so a really good drug to have. But I think afterwards the stocks weren't great, but we use it prophylactically in the UK
Yeah.
prior to Cesarean sections sometimes, as well as being on protocols, obviously as a standard for PPH management of more than 500 ml loss.
Mm-hmm.
I was just going to ask, does it need a cold chain? Do you need to keep it cold?
No, you don't. That's
Okay.
one of the really good things.
Good things about it.
And also, it's not an abortive drug, so there's no. I mean, because with misoprostol, that's sometimes a concern people have about handing it out in communities, etc. So
So
this
it
is
can't be used. Sounds great to me. The other question I was going to ask was, does anyone else have a question before I keep jumping in?
I've got one question.
Go.
So the woman trial is quite a big trial itself, and it's from the London School of Tropical Medicine, Hygiene and Tropical Medicine. I'm just wondering, in terms of the findings that you had, was there a stir from these findings? Did it actually bring about a change within the institute itself to actually try and push this agenda forward as well?
No, I don't think so. I did present it. I presented it at what was it called, Susannah? I don't remember. In Cambridge, some global maternal health conference in Cambridge, and
It was was it Glow conference?
Glow.
Yeah.
yes, exactly.
Glow.
And in Belgium as well at for the VVOG, the Flemish Association of Obstetricians. But and it's published, and I think if I remember well, it was referenced in the GLOSS study that will come out. So I do think, I mean, it's out there. People can read it if they want, but it's not been a very big. It is also a secondary data analysis, so it does have a lot of limitations and constraints that need to be taken into account. It's more I think it's more useful as a flagging of careful, there might be something going on here.
Yeah, because it could be the start of more research projects just to be able to bring about more information and then lead on to a policy.
Yes, because actually, yeah, what I didn't mention was that in a couple of population-wide studies from high-income countries, they also saw this association between hemorrhage and an infection. Like from the US, the database Susannah mentioned, where they have their healthcare insurance data. But yeah, it's always, I think one of the big strengths of the woman trial was that it included a lot of low middle income countries where if you're talking about maternal mortality and maternal morbidity, that's actually where the burden is. And so I think it's quite an important finding that this was like picked up in big databases from high income countries, but also seems to be relevant in low income countries.
I think one more thing is about the preparedness of the health facilities where these procedures are taking place, especially if we talk about C-sections or laparotomy. I'm not sure if the original study actually looked at what sort of health facilities are these procedures taking place, which are essentially leading to complications or sepsis, because is the health facility actually ready to deal with laparotomies and C-sections?
I don't know all the facility characteristics by heart. As I said, yes, surely there will have been big differences in the facilities, and we did not look at like sepsis rate per facility or whatever. I think that would not have been possible. But this is of course why we did decide to include the random effects and account for clustering by facility, because I think, yes, of course, without any doubt, it's easy to say you need to be careful and you need to have good infection prevention standards and whatnot. If you don't have the facilities, then what are you gonna do? And again, I can speak from personal experience there, because I used a lot less. I cleaned my hands a lot less when I was in the wards in South Africa than I did in Belgium, just because we did not have the hand sanitizer. And I mean, I think I'm rather passionate about this subject, and I understand the importance, and still I was definitely not doing it right, just because it's not there. So yeah, true. It doesn't help to have good guidelines. You need actual tools and stuff on the ground.
Yeah.
I suppose that highlights the importance of not having categories, like you said in your initial table: hemorrhage, hypertension, sepsis. And then if you need the political will to address this as an issue, I suppose it's really quite important to highlight the fact that sepsis isn't just sort of all the way down there after hemorrhage, and it is a sort of active contributor to the deaths from PPH.
Of course, and infection, because infection prevention and control is also larger than preventing antibiotics. I mean, it's antimicrobial resistance is gonna kill us all if COVID doesn't. So it has way larger implications than just trying to prevent sepsis. That's just the tip of the iceberg.
Yeah, maybe we can capitalize on this atmosphere to encourage sort of compulsive hand hygiene all the time. I don't know about everyone else, but my hands are sort of cracked and dry every time I go into the city. And then I looked at them, what are these snakeskin gloves that I've got on my hands? It's just my skin. Can I, chat thing. Okay, thanks to both presenters. Why are these women having laparotomies post-PPH? Am I just not thinking for...
So it might be second look. Yeah, so no, it's true. This is also why the laparotomy category is a bit of an enigmatic category. It does have the highest effect, but it might also be the one that has a higher bias if they do it for like washouts of infected pelvises. It can be a second look laparotomy because you thought you stopped the bleeding, but actually you didn't. Your artery ligation wasn't successful, or it's after a cesarean that you have bleeding, and you just didn't do your hemostasis adequately. It could be a washout as well. It's the laparotomy for other reasons. It could be miscoding as well, because they were supposed, if they did a hysterectomy, to just tick the box hysterectomy, not laparotomy. But we did see in the data that there were quite a few instances where they had ticked both hysterectomy and laparotomy. Was this true? Was this, as I say, like second look, and the second laparotomy was done in a second time, or is that they didn't understand the coding instruction very well, and they were like, yeah, sure, we did laparotomy to get to the uterus.
Sure. Yeah.
You can never. I mean, there will. It was a very pragmatic trial, which is really nice, I think, in terms of representing then the real life situation. And it has it did run in 193 facilities, but you do pay a price for that, and that's that your coding will be possibly not as accurate as it might have been if you had like one study nurse doing everything.
Any more questions or comments?
You added a highlight. What does that mean?
I actually don't know.
Okay.
I think people can sort of pick their favourite moments. I like to think it's a personal compliment that she had added a highlight when I was saying something.
I think it might have been
I
excellent.
think it might have been a mistake. I think that's hoping for too much. Thank you both, Drs. Wood and Cornelissen, for coming. I hope for everyone that attended that this was a refreshing change from the sort of topics we've been discussing day to day. Around, we sort of explored how they're interconnected. If nobody has anything further to add, we'll wrap it up there. Thank you very much.
Yes, thank you very much.
All feedback forms. We're very keen to hear your thoughts on what kind of papers we should be discussing at GASOC journal clubs next. So to those who are attending, watch out for the feedback forms and watch out for the link where you can actually suggest papers, because we want to discuss what you want to discuss and not just what we want to discuss.
Yeah.
So thank you for coming.
And lots of thank yous coming. Yeah, lots of thank yous coming from our audience as well to both Susannah and Laura. So really appreciate your input and sparing time to speak to all of us. So thank you very much.
Thanks for inviting us.
Okay.
Bye.
Bye, everyone. Bye.